Sir, you can start some.
Good evening, welcome back to Auricle. We'll be discussing health programs in India in this part 2. And Auricle is a very good platform for the revision of all important questions. And it is a 90-day Proff pre-final mastery program where we'll be doing volatile facts, quick revision, and it will yield high-end topics. And most expected topics will be covered in this sessions. Who are getting benefited by this? The students who are appearing for University Prof exams and next exams. Today we'll be discussing 90 days under 90-day University Prof pre-final mastery program. We'll be discussing long essays and short essays. Long essays will be discussing about family welfare planning under RCH program and AIDS control program in detail, and blood safety and ensuring blood safety and regarding blood donation. After that, we'll be discussing voluntary and counseling and testing centers, and we'll be writing the salient features of National Mental Health Program. Why do we choose Auricle? Auricle is such a good platform where we'll get 5 modes of learning, that is recorded classes, where you'll have flexible learning, and in which will be by our expert examiners and the educators, and we'll have convenient revisioning of all the subjects and topics at your own pace and at your own speed. Wherever you want to go, you can listen and you can see the classes also. Okay, live classes will be having in-depth coverage of all the live classes, and experienced educators will be teaching you how to write the answers, and study plans will be given to you, and you'll have many more surprises to come. And in interactive sessions, you will have clearance of doubts, MCQs, Viva OCs, and many more. We have something called Express exam module, where we'll be covering the whole syllabus in 20 hours so that you can revise your whole syllabus for your exams in a comprehensive and efficient way. And we'll be giving you all the exam writing skills, answer writing skills, flowcharts, and the diagrams so that you can write them and practice. This is all will be done by our expert examiners. We'll have one-to-one doubt clearing session also, where it is a safe learning environment for all the students with a student centric approach, where you will be having all the freedom to ask whatever the question you feel like and whichever comes into your mind. Okay. After this, we'll be giving you a hard copy note set so that you can read on your own whenever you want to, whenever you feel like. You don't have to listen, or if you don't have access to the live classes or the recorded session, you can learn from your hard copies books. And next we have the question bank, which is of 3 levels, that is beginner to expert level. It contains MCQs for all your prof exams, NEET PG exams, and FMGE exams. With this, we have practical sessions also, where you will be having one-to-one learning experience with hands-on experience, followed by Excel in practical examination, so that you can go with your full confidence to your practical exams. And we have 4 plans under Auricle, subscription plans under Auricle, that is foundation plan, which will cost you around 19,999, and 6 months plan, which is called advanced learning plan, which will cost you around 32,999, and complete learning plan, which will cost you 60,000, and ultimate MBBS plan, which is for 4 years, will cost you only 1.9 lakhs. However, you will be getting a good discount with the code displayed below. Please do use the code for good subscriptions. With this, we'll be starting our class today of National Program Session 2. Okay. First question is, what is the difference between family planning and family welfare? And describe the components and strategies under reproductive and child health program. Explain the various services provided to mothers under this program. I'll be adding the child component also, so that if any future exam comes in this question, it will be cleared. Next, we have we'll be describing what is family planning and family welfare. What is family planning? It concerned with enabling individuals and couples to decide freely and responsibility to the number and spacing of the children, how many children they want to have, and what would be the age gap between those children. And what are the services provided under this are education for family planning, like how many kids you should have for a good family or a healthy family, contraception for spacing the children, and temporary contraception and permanent contraception based on the number of children and spacing, and fertility treatments if there are no any if they're about to conceive and not able to conceive and they're planning for pregnancies, and that fertility treatment is also under family planning. Objective is to help people achieve their desired family size and contribute to better maternal and child health outcomes. What are the examples which you give? Birth control methods, sexual education, and counseling on family size. Okay. What is family welfare? It is a broader concept. It includes family planning. Family planning is a part of family welfare, and it also addresses the overall well being of the families. Does it include only health? No, it includes health, education, economic stability, and social services. Okay. Like in health, you are giving the family planning all, and anemia Mukt Bharat for controlling of anemia, JSSY for maternal health, all other nutritional programs are also there. And poverty alleviation by giving some incentives during pregnancy so that they will have the loss of pay is covered during that. It is some incentive so that they come and get the institutional delivery. And in family welfare, we have to enhance the quality of life members, like providing healthcare, financial aid during pregnancy, nutritional supplements, and educational support for families. Okay, this is family welfare. Family planning includes only about how, like number of children and spacing between the children. Family welfare includes health, education, economic stability, and social services, everything. Okay, that is complete welfare. Family planning is a part of family welfare. Okay. When was the reproductive and child health was started? The reproductive and child health was launched on 15th October 1997. Okay. And the RCH phase 2 was launched on 1st April 2005. After 8 years of RCH 1, the RCH 2 was launched. Okay. RCH 2 was launched with the aim to reduce maternal and child morbidity and mortality with increased importance on rural healthcare. Okay. With this, we'll be coming about components of RCH1. RCH1 had family planning, reducing child mortality and safe motherhood, healthcare delivery with client-centered approach, and treatment of reproductive tract infections, sexually transmitted diseases, and AIDS prevention and management. These were the four components under RCH1. Whereas RCH2 had different components. It included the previous ones also, and it has strategies, emergency obstetric care, like essential obstetric care, institutional delivery, and skilled attendance under RCH2. And emergency obstetric care had operationalized first referral units, operation of PHCs and CHCs, and round the clock delivery system and strengthening of referral system. Okay. What were the initiatives under RCH2? RCH2 and quality antenatal care, like 4 ANC visits at least, including early registration, and first ANC visit with first trimester. And essential obstetric care included 24/7 PHC services providing skilled attendance at birth. Okay. And postnatal care included ensuring that within 24 hours of delivery and subsequent home visits by the skilled health attendant or the skilled, what we say, ANM or the nurse, staff nurse or the lady health visitor or the ANM. All these, either one of them will visit on 3rd day, 7th day, 14th day, and 42nd day of postnatal period. First is essential obstetric care during delivery, and the second is postnatal care for mother and newborn, and provision for emergency obstetric care and neonatal care for at FRUs. What is emergency obstetric care? Emergency obstetric, sorry. Emergency obstetric care included like critical components of manpower, like availability of medical officer, surgeon, and anesthetist, and referral linkages and transport. Okay, referral services at both community and institutional level, which including transportation through ambulances. Okay, what were the strategies and interventions? Under strategies and interventions, we'll be discussing the services for mother. Okay, first we have Janani Suraksha Yojana. This is a demand promotion and conditional cash transfer scheme launched in 2005. What was the objective for this? To reduce maternal and infant mortality by promoting institutional delivery among pregnant women. It is a cash transfer scheme launched in 2005 for mothers for promoting institutional delivery among pregnant women. Okay. Implement with the objective reducing maternal mortality and neonatal mortality. What was the incentives? In low performing states, we had mother's package of 1,400 rupees and Asha's package of 600 rupees. In rural areas and in urban areas, it was totally 1,400, 1,000 plus 400. Whereas in high performing states, we had 700 plus 600 and 600 plus 400. Okay. This money was given to mother and Asha component was given to the Asha worker as a motivational and incentive factor. Next, we have Janani Suraksha Yojana, Janani Shishu Suraksha Karyakram, launched by Government of India on 1st June 2011. This entitles all pregnant women delivering in public health institutions will be free and no expenses will be given for any treatment for pregnancy, including cesarean section. This includes free drugs, diagnostics, blood, transport from home to institution between the facilities of one hospital to other hospital as a referral center and back to home. This is from home to home. Okay. Similar entitlements is also available for newborn, accessing the institutions within 30 days of till 30 days of birth. Okay. This is Janani Suraksha Yojana. This is Janani Shishu Suraksha Karyakram. Just not, yeah. In this, it is from home to home, includes end-to-end treatment services and facilities. It includes free drugs, diagnostics, blood and diet, and all other facilities. Okay. And we have Vande Mataram scheme for mothers. If any doctor who is a gynecologist, who has a nursing home, who might be working as in a maternity home or a lady doctor, they can volunteer themselves for providing these services free of cost. Okay. And once they have decided to give this, they can display Vande Mataram logo on their clinics. Okay. This is Vande Mataram scheme. Any specialist who is working in a maternity home, nursing home, or a lady doctor, they can voluntarily help the mothers by giving all these services. Okay, what do? They will display a Vande Mataram logo. That will be more than enough. And we have safe abortion services for mothers or the married women or eligible women for pregnancy. How do the medical method of abortion is done? That is with two drugs. One is with mifepristone and followed by misoprostol. If any complications are there, they are eligible for blood transfusion also. Okay. The other way of abortion is by manual vacuum aspiration. It is feasible and it can be done at primary health centers also. And we have nutritional services also for mothers. There's something called Village Health and Nutrition Day. It is conducted once a month at Anganwadi Center in the villages. For what? To provide ANC and PNC care to pregnant women and to promote institutional delivery by educating them and providing immunization for children, and family planning and nutrition services are provided. Okay. Next, we have Pradhan Mantri Surakshit Matritva Abhiyan. This is to provide antenatal care and high risk pregnancy detection in pregnant women on 9th of every month. It was launched in 2006. Next, we have Anemia Mukt Bharat program. It is a 6x6 strategy that focuses on 6 target beneficiaries through 6 interventions and 6 institutional mechanisms. Okay, who are the 6 beneficiaries? You should go by age 6 months to 59 months, that is 5 years, and 5 to 9 years, 10 to 19 years. After that, pregnant women, lactating women, women in reproductive age group. These are the 6 beneficiaries divided by age. Okay, then we have what are the interventions? Prophylactic and folic acid supplementation, because you will not be giving any deworming less than 59 months. You will be giving deworming in Anemia Mukt Bharat program after 5 years only. Okay, and for 10 to 19 years age group of adolescent girls and boys, there's a behavior change communication campaign like sex education, and their solid body, mind, everything will be taught. And for females, there will be a folic acid supplementation and deworming in both males and females, and appropriate infant and child feeding practices are given. And with this, if there are any 18 years and above, they'll be given how to delay the pregnancy. Okay. In pregnant women, testing and treating of anemia, using of digital methods for tracking of pregnant women. Apart from that, we'll be having mandatory provision of iron and folic acids. You can write it commonly that iron and folic acid will be given in all these. Okay. Only thing we have to concentrate here is behavior change communication in adolescents and teenagers, pregnant women, testing and treating of anemia, blood group, and HIV testing is done. In lactating, mandatory provision of iron folic acid fortified foods and government public health programs. Women in reproductive age group, they'll be given if they are treated for all these things, and the screening is also done for all these things. Okay. What are the 6 institutional mechanisms? Interministerial coordination, establishment of National Anemia Mukt Bharat Unit, National Care Center for Excellent and Advanced Research on Anemia Control, convergence on other ministries. What are those other ministries? Education Ministry, Health Ministry, Food, that is Social Services, and what else we include in this? Public Works Department. Okay. Strengthening and supply of chain and logistics, that is what we say food and nutrition services. and one-stop solution for anemia. One-stop shop solution for anemia. There's one more program called Laksh. This is program was introduced to accelerate the declining MMR. That means it is already declining. So we wanted to reduce it faster. Hence, this was launched. Why this was launched? To improve the labor room quality. Remember, labor room quality. By how? By strengthening the key process related to labor rooms, that is man, material, and infrastructure. Okay, so that the quality of care around birth and ensuring respectful maternity care. This was launched by Ministry of Health and Family Welfare. Okay. Next, we have Mother's Absolute Affection Program, which it focuses on end child feeding practices. This includes incision of early breastfeeding within 1 hour and exclusive for 6 months. And in this, it will be the mother will be taught about adequate complementary feeding practices after 6 months, and she will be encouraged to do breastfeeding for 2 years. Okay. Comprehensive abortion care for mothers. It is a component of RMNCH plus A. What is RMNCH plus A strategy? Reproductive, maternal, neonatal, child health plus adolescents. All categories from mother till adolescent are included. Okay. What are the maternal deaths as of now? That as of 8% as per the 2001 SRS. And I'll update on this. This is a little bit old. And this program is implemented as per the mandates of Medical Termination of Pregnancy Act. Okay. When was the Medical Termination of Pregnancy Act was launched? That was launched in 1971. There were further amendments were made on 12th October 2021. Okay. To provide safe abortion services. It depends. It decides who will, like how many doctors' opinions are required for terminating the pregnancy at what gestation age. If the gestation age is less than 20 weeks, there is only opinion of one registered medical practitioner is required. Okay. If it is 20 to 24 weeks of gestation, we have to get two medical officers' opinion, medical practitioners' opinion for termination of pregnancy. And if the pregnancy, termination of pregnancy is required for the diagnosis of any substantial abnormalities, if the baby is having any birth abnormalities, which will lead to further disability of the child in the future, then they can go for termination of pregnancy. Okay, it will be done by a board of medical officers in the hospital. And apart from that, there is a strengthening of privacy protection for women so that they don't have to tell which and women underwent medical termination of pregnancy. Okay, and if there is any failure of contraceptive use, even they can go for termination of pregnancy as per Act 2021. These are the child health components under RCH. I'll be going a little bit faster in child health because we'll be running short of time. We have a bigger topic again, that is National AIDS Control Program. We have nutritional rehabilitation centers where they provide 24-hour care for monitoring a child, treatment for medical complications like respiratory infections, complication of respiratory infections, nutritional complications like malnutrition leading to complications, okay, and diarrheal complications which are leading to complications like coma, severe dehydration, etc. Okay, and all other services are provided like counseling, demonstration practice of how to prepare food and the energy dense food, social assessment of the family identification. IMNCI is again a long essay which you should know, we'll be discussing later. It is one of the main interventions under RCH2 and NRHM. What is the relation between NRHM and NHM? First, we have NHM. Below that, we have NRHM and National Urban Health Mission. Okay. Under this, we have IMNCA package. All are included. All children from neonatal still till childhood are included in this. Okay. We have Navajat Shishu Suraksha Yojana, personal to be trained for basic newborn care and resuscitation. We have Rashtriya Bala Swasthya Karyakram, divided into two age groups 0 to 6 and 6 to 18 years. For what? To identify and provide early intervention for the below the age group of 18 years for any developmental abnormalities or identification of any other diseases. Okay. Adolescent health program, again, it to provide the comprehensive health strategy, nutrition, iron and folic acid supplementation, menstrual hygiene, information counseling services, reproductive and health services, which is called as ARSH, and preventive health checkups are done in adolescent health program. With this, we'll be coming to the next question, that is National AIDS Control Program. Okay, we have to explain in detail. This is the National AIDS Control Program, which was started in 1985. Imagine in 1985, the first response for AIDS was started in India, and we are in phase 5 now. Okay, it was initiated as a just as a serosurveillance, like checking the antibodies or antigens presence of this antigen antibody presence in the blood. This was started as that in 1985. Okay, we'll go by stage, step by step, with only stage one, sorry, say phase one, phase two, phase three, phase four, and extension phase. We'll learning about key strategies, and in detail we'll learn about 4 and 5. Okay, phase one, it was launched as an HIV zero surveillance project. Okay, and there was a national AIDS committee was formulated. Further, it included blood screening and awareness generation in the population. These were the key highlights of national phase one, which started from 1992 to 1999. Okay, in 1985 it started as zero sevens, but NACP phase one started from 1992. Okay, phase two was from 1999 to 2007. It was targeted interventions through what? Through national non-governmental organizations or community-based organizations. It was targeted interventions for the high-risk people, and there were establishment of voluntary counseling centers and PPTCT centers. Okay, and there was introduction of antiretroviral therapy and establishment of ART centers. Antiretroviral drugs were introduced and therapy centers were started in 1999. That is phase two. There was a National Parliamentary Forum and National Council on AIDS was formed, and there was National AIDS Prevention Control Policy and National Blood Policy was adopted in phase two, and capacity building for state aid control societies and establishment of public sector units and PMUs were formed. Sorry, preventive and surveillance units. In phase three, there was a rapid upscale of the service delivery across the country. Okay, HIV counseling services were offered for the pregnant women, and it was part as a component of ANC services. And there was uh, these are all surveillance intervention and medical unit. All these are not required. It was decentralized up to district level. That is, uh, district AIDS prevention and control unit was formed at the district level, so that all the programs gets implemented at the ground level rather than at the state or the central level. We have phase four. The key highlights include there was increase in the budget of NACP first and foremost, and there was a launch of helpline 1097, and policy was made so that even syphilis was also included to eliminate along with HIV. Okay, and NACP was launched in prisons and other closed settings also. Closed settings in the same, you can say brothel, etc. Okay. And this was included so that the diagnosis made easier. That is CD cutoff level for initiation of ART was shifted to 500 cells per mm cube. And there was a prevention and control bill was introduced in Rajya Sabha. Okay. And till now, there was no midterm reviews which was started in NACP phase 4. And there was extension of this phase 4 from 17 to 2021 with the act which was formulated, introduced here, got enacted here. Okay. And there was test and treat policies for HIV patients. And Mission Sampark was launched for people who lost or who could not come back for treatment. To get them back for treatment, this Mission Sampark was launched. PLHIVs means people living with HIV. Those who have stopped treatment or could not follow for treatment, they were brought back to start the treatment. This process was called Mission Sampark. Okay. And upscale in testing and DSDM for PLHIV to strengthen follow-up and adherence and retention. In this NACP 4, the drugs were given continuously so that they will not lose for the follow-up. And interventions were introduced in the prisons, as I told, and revamped targeted intervention program. Okay. And there were testing strategies, like there were mobile testing units were launched for hard to reach areas. And there was dolutegravir based regimen was introduced in this NACP extension phase 4. I know it is difficult, but you have to read it at least 3 to 4 times to remember all these things. Okay. Coming to the phase 5. Phase 5 started from 2021 and it is under progress as of now till 2026. What are the goals? Reduction of HIV infections by 80%, AIDS-related mortalities by 80%, and eliminate vertical transmission of HIV and syphilis, that is in mothers. Promote universal access to sexually transmitted diseases and reproductive transmitted infections services. Okay, and eliminate HIV and AIDS-related stigma and discrimination among the public, within the people. Okay, and we have guiding principles for that: using of technology, gender sensitive responsiveness, arrangement like using all the fostering institutions like private and public institutions, and increase their partnership, very good management, and strategic driven information, so that even the individual get tested at private center, they should be treated, he can get treated at government centers also. Okay, these were the 8 guiding principles for NACP phase 5. If you remember, write it, otherwise it is not required. What are the objectives? This you should remember. Objectives for 2, that is HIV and AIDS prevention and control, sexually transmitted infections or reproductive tract infections prevention and control. In HIV AIDS prevention and control, we have 95, 95, 95. Remember, 95, 95, 95. Whereas goal was 80, 80. Objective was 95, 95, 95. What is 95? 95% people who are at risk of acquiring HIV infection use comprehensive prevention. Okay. 95% of HIV positive know the status, and 95% of those who know the status are on treatment. Okay. And 95% of those who are on treatment should have suppressed viral load in their body. People who are at the risk of acquiring infection, if 100 people are at risk of acquiring infection, 95% of them should have access to comprehensive prevention care. What is comprehensive prevention care? They should have educational services, they should have Prevention services of condoms. If they are drug users, they should have opioid substitution therapy services, and they have access for needles also. Okay. If 100 people are diagnosed, 95% of them know their status, and 95% of those should know the status or on treatment. And those who are on treatment should have 95% should have reduced viral loads. Okay. Next 95% is pregnant and breastfeeding women living with HIV should have suppressed viral loads, or we should achieve 95%. That is 95, 95, 95 strategy. Okay. What are sexually treatment infections and STI prevention? That is, all the people should have access for treatment as well as diagnosis. All the vulnerable population and at risk population, and attainment of elimination of vertical transmission of syphilis. This is STI prevention control. We have package services for NACP4. Those include prevention services and care support and treatment services, which are also continued under NACP5. Prevention services. What are the prevention services? Who are getting it? Targeted interventions for high risk groups, bridge population. What are the bridge populations? Migrants. Truckers and migrants are usually the bridge population. High risk group are female sex workers, men who have sex with men, transgenders, and injecting drug users. These are the high risk people, and these are the bridge population. What is the other service? Needle syringe exchange program and opioid substitution therapy for injecting drug users. Needle syringe exchange program, it is a short answer where the syringes are given after use, they are collected back, or they have to be deposited back. And opioid substitution therapy, whereas you are using injectable drug users are given with opioids which can be consumed orally so that they will not get addicted for injections. Prevention of interventions for at source or transit or destination. How will we do this? By providing what? First is health education, educating them. Second one is access to healthcare. Third is preventive services like provision for condoms and testing. Okay. And link worker scheme. Link workers are health workers basically for high risk groups and vulnerable population in rural areas. Why? There might be a stigma and discrimination if they're coming to the hospitals and getting tested. To avoid this, we have link worker scheme. And what is the next prevention services we have? Blood safety, HIV counseling and testing services. We have blood safety and HIV counseling coming up again. Prevention of parent to child transmission, that is vertical transmission, and condom promotion at public places and accessible places like hospitals, bus stands, and any large gathering areas. Okay. Apart from this, we have information, education, communication, that is IC activities, BCC activities, adolescent health education programs, so that the sex education is provided at the early age, and workplace interventions and mainstreaming HIV/AIDS response. These are all the not so important services, but critical ones. Okay. And in the HIV surveillance services, we have surveillance of 6 types. First is HIV sentinel surveillance. We'll go through completely about this. Zero surveillance, that is random sampling for HIV cases. AIDS surveillance, who have developed the uh, acquired immunodeficiency syndrome already. Surveillance for sexually transmitted diseases, it could be active or passive. Behavioral surveillance of high-risk groups, that is people visiting brothels, truck drivers, migrants, injectable drug users, and LIFO. Integration with surveillance of other diseases like tuberculosis, because once the AIDS had set in, there's a reactivation of tuberculosis. So if the person who is old age or thin, lean, looking very unhealthy comes with tuberculosis, diagnosed with tuberculosis, he should be screened for AIDS also. What is HIV central surveillance? This is to monitor the trend of HIV infection. Objectives are to determine the level of infection among whom general population and as well as high risk population. High risk groups are different in different states. Okay. And to understand the trends of epidemic, to understand the geographical spread, is it increasing based on state or based on workforce or based on migration? Okay. To provide information on, so that the program resources are prioritized and program impact can be maintained. To estimate HIV prevalence and burden in the country. These are the objectives of HIV sentinel surveillance. We have counseling and HIV testing services under NACP. What are the activities done under? We have integrated counseling and testing centers, prevention of parent to child transmission of HIV, and collaboration activities with tuberculosis. Coming to the integrated counseling and testing centers, there are two types. One is fixed and another is mobile. Under fixed, we have standalone, that means they're independent testing centers. The other one is integrated facility centers. What is standalone? They are independent centers. They are established if the high client load is very high. It has full-time counselor and a lab technician who does the test and reporting is done and the counseling is being done. Where it is located? Either in medical colleges, district hospitals or sub-district hospitals and even CHCs. Okay. What is facility integrated? Facility integrated means there is a facility existing already. You have manpower who are not specially trained for this, but the available manpower is trained. In PHCs, there are only 2 or 3 nurses or one ANM or one head nurse and 1 or 2 medical officers. They are trained to do the counseling services as well as testing services. This is called integration into the health system. And public-private partnership support is provided with, logistics support is provided with district aid control centers and state aid control centers. Okay. What is mobile facility? This is fixed. This we have finished. Mobile facility is set up in hard to reach areas. What does it contain? It contains a mobile team. It contains health educator or ANM who can counsel the people, who will educate on the AIDS. There is a counselor for pre and post counseling and a lab technician for doing the test. Okay. This is the levels of HIV testing services in India. Standalone ICTs at state or district level, medical colleges, hospitals, and standalone is also there at civil hospitals and community health centers, and standalone facilities again at village level, facility integrated ones at village levels, primary health centers, NGOs, and at community level we have mobile or high risk for unreached population. What are prevention from parent to child transmission services? This is to offer every pregnant woman for HIV testing. What are the services provided are the mother is offered for HIV testing and counseling when they get enrolled at antenatal care. Okay. It should be a family centric approach. And once they are diagnosed, they are given lifelong ART to all pregnant women and breastfeeding women. And if they're detected to be positive, they undergo institutional deliveries. This promotion should be done for HIV positive mothers. Services, provision of care for all infections, including opportunistic. And again, nutrition services, counseling, and psychological support is also provided. Provision for antiretroviral drug prophylaxis to infants from birth up to 6 months. Integrated follow-up of HIV exposed infants. Okay. And ensuring incision of co-trimoxazole prophylactic therapy and early infant diagnosis. By how? By using DNA PCR at 6 weeks onwards. In whom? In children. Okay. Strengthening of community follow-up and outreach. By whom? By ASHA workers. Care support and treatment services include lab testing for CD4 testing and other investigations. First, free first line and second line antiretroviral therapy through ART centers, link ARC centers, centers of excellence, and ART plus centers. Pediatric ART for children and early infant diagnosis for HIV exposed infants and children below 18 months. HIV to TB coordination so that cross referral and detection are seen and appropriate treatment is provided. And treatment of opportunistic infections. There is drop-in centers for peer HIV networks also. This is a model of treatment for HIV services. We have link ART centers and link plus ART centers at the district level and centers of excellence at medical colleges or state level. With this, we'll be coming to the short answers. We are overshooting our time. So we'll go ahead briefly. Blood safety. What do you mean by blood safety? It refers to measures and protocols implemented to ensure that blood and blood products are safe for transfusion. And the goal is to prevent the transmission of any infectious disease to the recipients. Okay. How? One, by donor selection, screening the donor for their health, lifestyle, travel history to identify the risk factors. By how? By providing them the questionnaires. Other one is blood testing. All donated blood are tested for HIV, hepatitis B, syphilis, and other pathogens. Blood typing is typed to ensure compatibility between donor and recipient. Blood safety does not mean only infections. It also means blood typing for acceptance of the blood so that the cross reaction or the anaphylactic reactions are prevented. How it is obtained done? Component separation. Even this has to be typed. Storage of blood under controlled conditions should be maintained to maintain their quality and safety. Transfusion practices, this include cross-matching and monitoring. Okay. Cross-matching to ensure compatibility and monitoring to what? Adverse conditions or anaphylactic reactions. Okay. Once it is done, there should be a tracking system also for continuous improvement of safety protocols. It is not that once a transfusion is done and left out, the individual should be tracked and any report delayed adverse events are there, even they should be reported. There's a policy on blood donation. Blood donation is voluntary. What is the eligibility criteria for donors? Age 18 to 65 years, must weigh at least 50 kg, must be in good health and free from any transmissible diseases. Screening, pre-donation screening includes questionnaire, a physical examination for risk factors and health. Testing, it includes HIV, hepatitis B, syphilis, malaria for testing. What is the frequency? Men can donate every 3 months, women can donate every 4 months. Platelet donation can be done more frequently, that is every 2 weeks, that is fresh frozen plasma. Or platelet concentrate can be donated every 2 weeks. Most commonly used in dengue, hemorrhagic fever. Blood bank regulations. Blood banks must be licensed and they should adhere to guidelines for collection, testing, and processing of storage of blood, and regular inspection and audit should be conducted. Public awareness and education should be provided for community participation and to avoid myths that blood donation causes something else or blood donation will cause weakness. All these misconceptions should be avoided. Hemovigilance to track the adverse events, and good infrastructure and accessibility should be there, including for rural and urban areas. Second, we have voluntary counseling and testing centers. These are the centers which provide confidential HIV testing and counseling services. How? We'll see that. Why do we require this? Are they play a very crucial role in identifying and controlling and preventing HIV or AIDS. Okay. What are the key components of this? That is voluntary HIV testing, pre-test counseling, and HIV testing and result disclosure. We have post-test counseling and linkage of case and support services. Okay. HIV testing voluntary. Okay. Any individual can go and approach the VCTC center if he wants to undergo HIV testing. Okay. And it is completely confidential. Before that, he is also explained about the testing and the HIV. Before the HIV test, they require counseling to understand the purpose of the test, why it has been done, and how to deal with the results. And they discuss the individual's risk factors for HIV and assess their readiness for the test. Information is provided on how the HIV is spread and what are the prevention strategies and importance of early diagnosis. Testing and result disclosure is also part. Testing is done by rapid diagnostic test, and once the results are ready, post test counseling is conducted in a very private and sensitive manner. How? If the test is negative, the emphasis is based on reduction strategies or to remain negative. How to remain HIV negative? If the test is positive, support is provided to help the individual so that he will cope up with the result and understand the next steps. What are the next steps? How to get treatment, where to get treatment, how to keep himself with the low viral loads, and how to avoid the risk factors more. Okay. And once the test is positive, they will be linked with ART centers for treatment. Okay. That is linkage to care and support services. The objective is to provide prevention and awareness, early detection and treatment by doing testing, behavioral change so that if the test is negative, it does not go into the high risk category again. And if the test is positive, explaining how to accept the positive result and to undergo the treatment, and support for infected individuals, that is care for treatment services and support services. Okay. Role of VCTC is HIV prevention, but that is testing coverage, targeting high risk groups. Who are the high risk groups? Sex workers, intravenous drug users, men who have sex with men, truck drivers, migrants, all these people. Okay. Conducting community outreach programs on testing and prevention methods, and reducing stigma and discrimination is one of the sensitive areas, which is also a role of VCTC. What are the challenges faced by VCTC? Please do write this. That is stigma and discrimination. Despite efforts, it is in India, it is still a very discriminating feature of if the individual has HIV. Limited resources. A counselor and a lab technician and an ANM or a health worker cannot look up the area of 1.5 billion where the population is very huge and people migrate from place to place for jobs, and there is high risk groups of drug users and drug individuals also, so this should be taken care of. Follow up and linkage to care. If the individual, how efficiently or how practically the individual go and takes the treatment is a one of the challenges still exists, and follow-up of treatment is one of the challenges which are faced by VCTCs because of the construction workers, truck drivers who are migrants from place to place. It has a very good impact. This you can write it on your own. Okay. Last question what we have for today is salient features for National Mental Health Program. It was launched in 1982 to address the growing burden of mental health issues, and there was no any mental health infrastructure in India. To address this, the National Mental Health Program was launched in 1982. That is before our birth. Okay. What are the objectives? Ensure, encourage, and promote. ensure the availability and accessibility of minimum mental health care for all, particularly who the vulnerable and underprivileged sections of the society of the population. Who are the under vulnerable? Vulnerable are children who are mentally challenged, and underprivileged sections based on the casteism, based on the uh, poverty lines, all this, and encourage the application of mental health knowledge in general healthcare, that is integrating with general healthcare and giving a social development. Promote. What is whom do we promote? Promoting people to get access of healthcare and approach for mental health services and self-help in the community. There's still stigma that people don't come and get mental health help. What are the components? Treatment, rehabilitation, prevention, and promotion. Treatment of mentally ill by providing necessary treatment and care. Rehabilitating, like offering rehabilitation services to help individuals so that they can go back and get accepted in the community. Prevention and promotion, like prevention of mental disorders and promotion of positive mental health. These are the three components. What is district health mental health program? It is launched in 1996 based on the Bellary model, which includes early detection and treatment, that is identifying the mental health issues at an early stage in the age. It could be childhood age group, or it could be adolescent age group. Okay. Now, once you have identified, you need some people who to diagnose and treat. Do we have sufficient people for that? Training of short-term training for general physicians so that they can identify or diagnose and treat common mental health problems, not the severe ones, at least the common ones. Creating public awareness. How? By giving media outputs or videos over the media, and creating awareness in the schools, workplaces, that mental health issues are there and how to discuss about this, and reducing the stigma of mental health, and monitoring them once the patient arrives and following them up is also part of district mental health program. I know today's class is a little bit boring, but please do try to cope up. Okay. What are the strategies? Integrating training, developing, and enhancing. Whom should you integrate? The mental health services should be integrated with primary health care so that person going to a mentally or a institution like Nimans, it attracts stigma, so that person should be able to get the mental health services at the primary healthcare itself. Training. Whom do you want to train? All the manpower at all the levels. Doctors, staff nurses, ANMs, to identify the symptoms and to mobilize the people. Developing community-based mental health services so that the stigma is reduced, and creating awareness also. Okay. Implementation. The program is implemented at all the levels, that is state and the district levels. And it is very important to uh, involve the non-governmental organizations to reduce the stigma and to get the very effective mental health services. Okay. The recent institutions are infrastructure and expanding scope of mental health services to areas like child and adolescent mental health, geriatric age group, and workplace. That means comprehensive and overall coverage is done for complete age groups. Okay. With this, we'll be completing today's class. We have social media handles for Auricle, that is YouTube, Instagram, Facebook, and Telegram, and we have Android app as well as iOS app for the Auricle. Please do subscribe with the code for very good discounts. I know today's class was very much boring, but national health programs are like this. Once or twice, if you revise, you can be able to remember. Thanks for watching. See you in next class. Thank you.